Good afternoon, everyone. It is 1 o'clock Central Time. So we're going to just wait 1 minute just to let everybody else sign on before we begin today's program. While we're waiting, are there any questions that anyone has?
Are you sure it's 1 o'clock?
Uh, Don, I can't hear you.
I just said, are you sure it's 1 o'clock?
I'm sorry, it's
1:30.
1:30. It's 1:30. I was thinking about another meeting there. I started at 1 o'clock. It's 1:30 Central Time. Thank you, Don, for catching that. I tend to be 30 minutes behind all the time.
I'm worse than that, so
Okay.
no
Well,
complaint.
it's now 1:31, so we're going to go ahead and get underway. And I want to welcome everyone today to this Hospice in Corrections. And today we're going to be talking about quality guidelines that were developed by the National Hospice and Palliative Care Organization, back in 2009. Before I do that, I want to remind everyone that my name is Jamie Boudreau. In case you need to get in touch with me, this is my email address. This is my telephone number. We also have on the line with us today Marquetta Lipford, who is our education director for LMHPCO. That's Marquetta's email address and her telephone number if you need to get in touch with her. She's in Corinth, Mississippi. I'm in New Orleans. We also have on the line, thank you, Lisa. Lisa Sigsworth is one of our outstanding members who has been helping us with a lot of educational programs. She's actually coming to us from Texas, right, Lisa? And you will be meeting Ann Walker in the last session, who will be going over state regulations with regards to hospice in Mississippi and Louisiana. And last week, you met Kathleen Supiano, the social worker researcher from Utah. That's her email. If you have any questions, to get in touch with her about any of the research that she did inside of corrections with regards to hospice. I want to remind everyone that you are now a member of LMHPCO. As a provider inside of corrections, we grant everyone special access as a member. And as a member, you have a login. Your login credentials are going to be your email address is your username, and we set up a special temporary passcode for you of PASS1234 exclamation point. Once you log in, you'd simply go to www.lmhpco.org, and up in the right-hand corner, you will see a little sign. It says login. You click there, put in your email address as your username, and pass1234 exclamation for the first time. And then once you get inside, you can set up your profile, and you can change your password to whatever you want to do. You have access as a member. You'll have access to all sorts of special pages that are not available to the public. They're only available to our members. You will also be receiving, when you log in, when we have conferences or workshops or things like that, you get member rates as opposed to non-member rates. And there's also, I want to point out to you, you have an option of signing up for leadership. We do have a task force on corrections, and I encourage you to consider becoming part of that task force on corrections. We'll be talking a little bit more about that task force a little later in today's program. In terms of continuing education, I want to remind everyone that we have 9 more sessions that we will be doing over the coming so many Tuesdays, 9 more Tuesdays ahead of us. You must sign in the chat box when I tell you to. When you're directed, I'm going to ask you to sign in, and that's where you sign in. You type in your name in the chat box, and you're going to type in, not right now, not right now. You have to do this when you're directed to. You can type in your name and your email address. You must attend the entire session to get the continuing education credit for physicians, nurses, social workers, and chaplains. Following each session, you're going to receive an email from us with a link to an evaluation form for that particular session. Most of you, anybody who was on last week's call, you received that email this morning. And you should look in your inbox and see the link. And you have to click on the link. You have to put in your name, your email address, and then you begin the survey. And it's just going to ask you some basic questions about your experience of last week's session. Each week, you're going to receive a new evaluation. You have to complete that evaluation in order to get the credit for that session. If you attended last week, you see it. You should see that in your inbox. If you don't, please let me know. I will tell you that as of about 15 minutes ago, 12 people out of the 43 who were on last week's call who signed in had completed the evaluation. So that means that there's another 30 folks on today's call who have not yet completed your evaluation from last week. At the end of today's session, within 24 hours, you will be receiving a new evaluation for today's session. I also want to remind everyone that we are recording these sessions. You can, if you look in today's calendar invite where you click to get the link for today's, you're going to see not only the document that I put in there for today's session, but you're also going to see a PDF of last week's slides. All of the slides or have the hyperlinks are all active, and on the very first slide, you will see with the title, Introductions and Orientation. If you click on that link, you can actually pull up the video of last week's session. Everyone you can view those sessions as often as you want. However, in order to get credit, you have to be part of the live presentation. You can go back and refer to those videos. You can share those videos with anyone on your staff, but people who simply view this video cannot receive the educational credit that we're offering. Or are there any questions? Okay. And feel free to stop me at any time if you have a question about anything that we're going to be discussing today. I do want to point out this is the schedule for the upcoming sessions, and we'll be marking them off as we go. Today, we're going to talk about quality guidelines that were written by the National Hospice and Palliative Care Organization. And I want to thank the Franciscan Missionaries of Our Lady Health System for making your continuing education credit possible. So there's an 11-week session. These are the dates. I do want to point out that we are skipping the last Tuesday of May, and we'll have to pick it up on June 3rd, simply because there's a state holiday that most folks will be observing in corrections. Again, I'm going to pick up where I left off last week in terms of some of the things that we weren't able to cover. But I want to remind everyone, the reason that we're doing this is that in Mississippi, according to Mississippi stats, you have almost 1,000 individuals incarcerated who are over the age of 50. And this is where we start seeing a lot of healthcare issues arise that we think that hospice is there to help you address. In Louisiana, there are over almost 5,000 inmates who are at the age of 50 or over, and these are the locations where we are currently have hospice volunteers and staff that are working with individuals. In Mississippi, we've trained the inmate population there a number of times at Mississippi at Parchment, and we're looking forward to opening programs both at Mississippi Correctional Institute for Women and at Central Mississippi Facility. I'm going to start off with a brief video that was done about the Angola hospice so that you get a little feel for what's involved in actual hospice. And I apologize.
Hey, Jamie, we can't hear it.
Sorry about that. Share computer sound. Okay, let's try it again.
Still can't hear it. Hey, Jamie, we still can't hear it.
That's right. What is that? Share computer sound. Oh, I'm sorry. Okay. I'm sorry. I hit the wrong button.
First-degree murder, 7 years on death row.
I was convicted of second-degree murder.
I walked in the house, shot her, and left.
This is the worst of the worst inmates.
Guy came to buy some drugs. He wound up getting shot.
I thought I had to be like everybody else, a savage animal.
It's pretty tough prison.
This is Louisiana State Penitentiary at Angola.
The average sentence here is about 93 years.
More than 85% of Angola's inmates will die in prison.
They know I need the biopsy. They keep setting it back, setting it back. I need help.
I know you do.
I'm watching dudes die here daily. Ain't nobody going home and got life sentences. This is death.
Hospice is a way to die with dignity with your family. And this is their family.
Can we do anything for you?
Why am I here? Sometimes I don't know why. You know, it's just something in me that just want to do the opposite of everything bad I ever did.
Everybody can't handle, just being around the time.
Oh,
Get the out of here. I don't need.
I don't know if I could be that person that sits there when the patient dies.
I wouldn't volunteer to do it, but they do, and I appreciate it.
How you feeling? You all right?
Feel helpless. One of those breaths could be his last one, you know.
You put so much into it only to watch them die.
Something in you gonna open up, or you not human.
Okay, brother. Rest in peace. For the guys that have done this for years now, had they had the compassion they got now, had they had it on the street, they would have never committed the crime they committed to come here.
Hospice is referred to as a process of helping one die with dignity. But more than that, I feel it's helping one live our life with love.
Hospice is the ultimate test. Have you changed or have you not? This is your chance to prove it.
A group of inmates are about to put themselves to that test. Can they find redemption, serving life?
Let's see if we can Now we have to get rid of this again. Okay. No, I don't want that. Sorry. We go here. Okay. Okay, that's a program that was done back in 2016 by Oprah. It's called Serving Life. We actually bought a number of copies and distributed them throughout Louisiana and also at Parchment. I would imagine that at least those facilities that had hospice programs back in 2016, you have it in your video library. You may want to pull that out and show it to your staff. It's 88 minutes long, and it's a great compilation of what's going on inside of corrections as well as hospice when the two are merged together, and the incredible program that is possible. When we're talking about hospice, we're talking about palliative services. Palliative services or pain management, symptom management, psychosocial, emotional, spiritual support, and bereavement support for the surviving members of the family. This is what we do day in and day out throughout Louisiana and Mississippi. You will be hearing more about palliative care from Marquetta Lipford beginning next week. She is going to take you through 8 modules around palliative care, what palliative care means. Palliative is simply a word, a Latin word that means to cover. When we can't cure, we can at least address those things that, or mitigate against the pain and the symptom, the psychosocial, emotional, and spiritual issues that arise when we're dealing with a very serious illness. These services are delivered by the interdisciplinary team. The team is made up of a physician, a nurse, a social worker, chaplain, and the volunteers. Inside of in the free world. In corrections, we add Angola has added security and classification, which are vital to the success of any program. Security and classifications have to be involved in these conversations, otherwise things just don't happen. The program just didn't work. So it's really important that you make sure at all of the facilities that all of these folks are involved in the discussions around hospice, around your hospice patients, and the plan of care that is being developed for each one of your patients. In 2009, the National Hospice and Palliative Care Organization, along with the American Correctional Association and the National Commission on Corrections Healthcare Accreditation, worked together to develop guidelines. And again, these are guidelines. We wrote them as standards. For those of you who are involved in healthcare, you understand healthcare standards. We wrote these as standards. They are guidelines for you to consider in terms of a successful program. These guidelines, there are 9 domains that we, in each domain, there are a set of standards. And the numbers that you see here tell you how many standards are inside of each one of the domains. We're going to go through these standards. There are 72 standards that were developed in these 9 domains. You have the complete, you have a copy, a PDF of the complete set of guidelines in today's calendar invite. You will see a PDF, and it's 92 pages on these domains. We're going to go through them, but I'm not going to read each standard. We're going to just look at them, and I'm going to give you time to read them. And if you have questions around those standards, I want you to feel free to unmute yourself and ask those questions. For those of you who are healthcare providers, these standards are not going to look strange at all. They are they're very much in line with the community standards around providing healthcare services. So The very first domain is incarcerated patient and family-centered care. This isn't an unusual concept for those of us who have been working inside of healthcare, whether that's in a hospital, in hospice, or at home health, or in any of the healthcare sectors. This should look fairly familiar to you. It's providing care and services that are responsive to the needs of the patient and the family of choice. The family of choice is how your institution is defining that that unit of care, and exceeding the expectations of those we serve. So I just want to take 1 minute, and I want you to read through. You'll see PFC1. That stands for Patient Family Centered Care. So you'll see that's the way standards are written. Please just read through these 7. And if you have a question about any of those 7, please unmute yourself and ask that question. Are there any questions around any of these 7 standards? And let me back up. There's no such thing as a stupid question. These are healthcare standards, and we just want to make sure that regardless of your field, you understand what we're talking about when we talk about these sorts of standards. Okay, the next domain is ethical behavior and incarcerated patient rights. So again, these are upholding the highest standards of ethical conduct and advocating for the rights of incarcerated patients and their families, as well as for your volunteers. So we'll take 1 minute and look through these particular standards. Again, I don't think that is healthcare providers, anyone's going to find any of these to be radical standards with regards to the type of care that you receive, whether it's in the community or inside of corrections. Now, with the standards come also a list of rights and responsibilities of the patient and also of the hospice volunteers. So and I do want to go over these because I think that these are important to impress upon all of us. The incarcerated hospice patient has the following rights according to the guidelines here: to be cared for by a team of professionals and volunteers who will provide high quality, comprehensive, and comfort-oriented services as needed and appropriate. To have a clear understanding of the availability and access to program services and the program team. To have appropriate and compassionate care, regardless of diagnosis, race, age, creed, disability, or sexual orientation. To be fully informed regarding health status. To have the opportunity to participate in the planning of their health care. To have assistance in identifying the services and treatments that will assist them in reaching their goals. To be fully informed about the potential benefits and risk of all medical treatment and services suggested, and to accept or refuse those treatments and or services as appropriate to their own personal wishes. Number 6, to be treated with respect and dignity for their person, family, caregivers, and property. To have caregivers who are trained in effective ways of caring for them when they are no longer able to provide care for themselves. They have the right to confidentiality with regards to the information concerning their health status, as well as other details regarding their incarceration and personal history. And they have the right to voice grievances concerning their care or treatment without being subject to discrimination or reprisals, and to have such grievances investigated. That's the rights of the hospice, the incarcerated hospice patient. Are there any questions or issues, or anyone have issues with any of these rights?
Yes, sir.
Yes, sir. Yeah.
I haven't heard anything.
Oh, I'm sorry. I thought someone said they had an issue. Okay, now the next set is the rights and responsibilities of the hospice volunteers that are going to be trained in your facilities. They have the right to be responsive to change. They have a responsibility to be responsive to the changes in their patients' needs. They need to be looking out for their patients to help the patient express concerns and support their decisions. They have a responsibility to evaluate the presence or absence of safe environments for the patient. They have the responsibility to report on levels and types of assistance needed by the patient. They have the responsibility to assist the patient in requesting additional helps or services. They have the responsibility to help the patient interact positively. The responsibility to assist the patient in developing realistic goals. They have the responsibility to allow the patients to talk or not to talk about their conditions. They have the responsibility to alert patients when visits will be missed. They have a responsibility to ask patients what they want to do. They have a responsibility to support other team members and staffs in their care of patients. And they have a responsibility to be truthful, kind, and respectful. Are there any questions or issues around the responsibility of the volunteers? Okay. The next domain is clinical excellence and safety. This is to ensure that the treatments and the services and care that you're providing is promoting safety through standards of practice. That we're not just making this up on the fly, but that this comes from um, uh, careful consideration of standards for practice. There are actually 18 of these standards, and so we're going to look at the first 9 on this page. Again, you notice that the IDT, the interdisciplinary team, is core, is vital in the delivery of all of these services. This is a team effort. I want to point out number 8. In your plan of care has to implement and evaluate plans for environmental safety and security. Every IDT, every interdisciplinary team meeting has to focus around the needs of the patient, but also the security issues that are involved. And everyone on the team is in agreement with that plan of care. I don't think this is any different from anything that you're currently doing, probably doing already in your facilities. Any questions on the first set of 9? Any comments on the first set of 9? These are the next set of 9. Any comments or questions about the clinical excellence and safety standards? Again, I don't know if that there's anything in conflict with what you're currently doing. And part of the reason for these guidelines is to actually affirm all of the things that you all are already doing inside of the correctional facilities with regards to treatment. Okay, we'll go on to the next the next domain, which is inclusion and access. This is promoting an environment of inclusiveness in the correctional community by ensuring that all people, regardless of their race, ethnicity, disability, sexual orientation, age, disease, or characteristics, have access to hospice services and end-of-life care programs. You know, this is nothing radical about this. It's just making sure that these services are available. I will say one of the biggest the issues that we face is providing bereavement education and supportive services inside of corrections. This is an issue. This is a big issue. There's a lot of grief, a lot of loss that the incarcerated are dealing with. And when we don't deal with those grief issues, when we don't deal with those issues surrounding loss, people tend to act out. I just want to make sure that you're thinking about how can we provide more grief and bereavement support to folks, not only for the family of choice that are incarcerated, but also when you're incarcerated individuals are dealing with the loss of a family member outside of corrections. You know, that's when people tend to act out when they feel helpless about the conditions of their family members. And bereavement services are an important part of allowing folks to deal with the reality of loss. The next domain is organizational excellence and accountability. Building a culture of quality and accountability that the general population, as well as your volunteers, recognize. This is where you really build trust between your hospice program and your inmate population. Data collected and distributed to appropriate individuals in a timely manner. I think, you know, making sure that your clinical notes are clear and that they're complete is very important, especially when you're going to look back in terms of trying to create either what we call a QAPI to test to make sure that your processes and outcomes are meeting the highest standards. The next domain is workforce excellence, where we foster a collaborative, interdisciplinary environment that promotes inclusion, individual accountability, workforce excellence, professional development, training, training and support for your staff and volunteers. Now, it's important that end of life hospice education is continuous. We will do everything that we can to try and help you with that task. But this is also a task that has to happen inside of corrections on an ongoing basis. Please take a look at these standards. Any questions about workforce excellence? I also want to mention here that one of the things that was very important in terms of getting the hospice program at Angola off the ground was that not only were the treatment staff and the hospice, inmate volunteers trained, but this became part of the orientation program for everyone coming into the facility, every new employee. Every employee needs to know about what you're trying to accomplish and that the hospice program is part of your institution. Everyone needs to be on the same page with regards to the importance of this program. And now we're going to talk about the interdisciplinary team a little bit. And it's important to remember the members of the interdisciplinary team. First and foremost, the physician. The physician's leadership is vital to a successful hospice program. I'm going to look at it real quick. The medical director has leadership role. The medical director recommends an inmate patient for admission to the hospice program. Progress reports regarding the inmate patient are available to all healthcare practitioners, and the attending physician receives an explanation of their responsibilities annually. Docs have to know what the expectations of them are, and they have to be uniquely involved in these decisions in the medical the plan of care. Any questions? Do we have any docs on today that are?
Jamie.
Yes.
Hey, it's James Delaney from Hunt.
Yes.
I mean, it was Clara. I wanted to just check this because we were talking about this as we're trying to get ours with some different docs over the skilled nursing unit, and I talked to you about that Zoom. I just wanted to clarify for my own sake. So when a person's going to be brought into end of life, how is that generated in your experience with Angola and other correctional facilities, as far as who's bringing them in? Is it more that the diagnosis from the hospital giving them a terminal illness and saying that no more curative measures can be found is what spurs the doctor on our end, the medical director, to sign something in the chart, putting them into end of life? And then at that point is when the social worker and other staff, nurses get in and do their paperwork? Or how's that process in your vision kind of?
Okay. Well, Jay, this is a really important question. In the free world, you have to remember, in the free world, most hospice is paid for by Medicare and Medicaid and private insurance. And those Medicare and Medicaid require that two physicians have examined this patient and that in their best clinical judgment, that patient has a life expectancy of 6 months or less. That's the rule for Medicare and Medicaid patients. You have to remember whoever's paying the bill gets to make the rules. Okay, so inside of corrections, there is no Medicare or Medicaid reimbursement on these patients for the most part. I've heard that there have been some inmates who do have Medicare and Medicaid, and there have been some attempts at collecting. Corrections has collected some money from Medicare for those particular patients. That's a rare occurrence, but for the most part, there is no Medicare, Medicaid reimbursement. So each facility does this a little differently. We recommend, first of all, that there has to be a terminal diagnosis that is established, and that's only done. Diagnoses are only given either by an MD, an OD, and we are beginning to see nurse practitioners being able to do more diagnosing as well with certain situations. So certain training. So you all, as a facility, actually need to know what the or you all as a facility are going to be deciding what that process is. Are you going to rely upon your outside contract hospitals to make that sort of diagnosis? Or is your doctor, your inside doctor, your doctor who is contracted to provide services in your treatment, are you going to rely upon them? Usually you're using outside services because they have a lot more diagnostic equipment to make those sorts of determinations, whereas you may not have those diagnostic tools inside. Is that the issue for you all?
Yeah, yes, that part is happening. It seems that's who generates it. It was just a discussion about, like, once they're given that type of diagnosis and that prognosis from the outside physician, it's about, at that point, I guess was my question, where it comes into line of the patient wanting to get in versus the doctor placing them in, or at least offering it to them on our end, our medical director, because they're going to follow the orders. Our medical director is going to, or his designee is going to follow the orders given by the hospital. So for the diagnosis first, it has to qualify that. We don't have a problem with that part. It's more, once they are having that, it's determining, because you're right, Medicare and Medicaid don't come into play really for the majority of them. So it's just, at what point do we offer them the opportunity to be in the end of life? Obviously, they have to want to do it, but versus them volunteering themselves, it's more us going to them with it, and it's who generates that. Is it an order written record versus is it something that we're going and talking to them about? I mean, obviously that we still have to get their buy-in, but that was really more my question.
Right. Well, in the free world, it happens that, patients or families say, we think we need hospice, but you still have to have a physician writing the order for it. And there's still a physician has to be involved in saying, yes, in my best clinical judgment, this patient, it does have a life-limiting illness that I believe in Medicare within 6 months. That 6 month period of time only applies to Medicare and Medicaid patients. If you have a private insurance patient, for instance, in the free world, and the private insurance says, it's not just 6 months, we'll go a year or 2 years, in terms of they see a trajectory of their disease process going over a 2-year period. Like I said, whoever's paying the bill, they get to make the rules as to when a person is appropriate for hospice care. So that's something, that your medical director should be taking into account. And, we can certainly have a lot more discussion around this because it's in their best clinical judgment. And who's making that clinical judgment? It would have to be someone, an MD, a DO, or in some settings, a nurse practitioner can do that. They can't do it in the Medicare world, but that's not to say that it cannot happen in your treatment facilities. Does that help?
Yeah, that does help. Thank you.
That helps a lot. Thank you.
Okay.
Hey, Jamie, and if you don't mind, may I add a comment there?
Please do.
I think the overreaching goal of these trainings are to not only educate, but just have more conversation around hospice and palliative care so that you guys will provide education or lean towards speaking about hospice and palliative care earlier so that will be able to improve the overall quality of the patient's life. Because the earlier that they can get these services, then the better overall level of quality of life that they'll have.
Thank you, Marquetta. And you'll be hearing more from Marquetta beginning next Tuesday as she takes you actually into the realm of palliative care. The next vital person on the interdisciplinary team is the nurse. The nurse is one of the primary, while the doctor may be making the determination as to whether or not the patient is appropriate for hospice, the nurse is the person who's really building the plan of care around that patient. And in a lot of instances, the nurse is leading the hospice team's efforts around the care of that patient. Here it's a qualified healthcare professional who's coordinating the IDT. Nursing services are based on initial and ongoing assessment of the inmate patient needs by a registered nurse and are provided in accordance with the interdisciplinary team's plan of care. Nursing services are available on a 24 hours a day, 7 days a week, and meet inmate patient needs in accordance with that plan of care. Medications and nutritional products are properly stored and prepared. The nurse is responsible for making sure that psychosocial spiritual services are being initiated and for that individual. That they're doing a complete assessment that is performed and documented for each admission. Each nursing visit and includes a reassessment of the patient's physical status. I will say, in the free world, you're constantly reassessing the patient's status or level of their status, because there are times where the type of care that we are providing to these individuals will actually help improve their situation. I can recall a number of times where we've enrolled patients who had a cancer diagnosis, a terminal cancer diagnosis, and over the period of time, with the type of care that they were receiving, they improved to the point where they were no longer hospice appropriate. I can think of one case at Angola in particular, where this one individual went into hospice. He got better, came out of hospice, relapsed, went back into hospice, became a hospice volunteer, and then went back into hospice. If you were at Angola in those early, you remember this does happen, and the nurses are vital to making that assessment in terms of whether or not a patient continues to decline or if they're improving because of the quality of care that's being provided to the individual. And I see, Chaplain, I see you nodding your head. You remember you know who I'm talking about. You have to unmute yourself. Let's see. You have to unmute you. You have to click on the little microphone at the the left-hand corner, bottom corner, if you want to say something. But it does happen. It happens in the free world. We see about 3% of our patients each year who come into hospice, and that number is rising. But we see about 3% of hospice patients who actually, quote, graduate from hospice, who are discharged from hospice because they actually, their conditions improve. Can't explain it other than to say the quality of care that the people receive does affect their healthcare status. Social work. I want to say,
Floyd.
I'm sorry?
His name was Tommy Floyd.
Yeah, you know it. Yeah, yeah. It was an amazing story, and completely baffled everyone. But it happens. Important social workers provide a very unique and important service in hospice in terms of doing those psychosocial assessments, making the contacts with family members and trying to reconnect inmate patients with family that maybe they lost contact with. They also provide a lot of psychosocial support to the individuals throughout the course of their throughout the course of what we call their enrollment into hospice. I know we have some social workers that are on today. Do you have any questions or comments that you would like to make? According to the standards for hospice social workers, they're identifying the inmate, patient, and family psychosocial needs, assessing and strengthening the inmates' coping skills, assessing and enhancing the responsiveness of the environment, and connecting inmate, patient, family with the community resources that are available, providing interventions for specific symptoms like fear, grief, depression, anger, screening for psychopathy, educating and intervening accordingly, assessing and referring for ongoing bereavement services or treatment, documenting problems, psychosocial assessment, appropriate goals, care provided, interventions, maintaining the dignity of the dying, being an advocate for the patient inmate, supporting inmates' unique spiritual and cultural belief, providing holistic family-centered care across treatment settings, consulting and collaborating with the IDT, and reporting abuse and neglect. These are some of the things that social workers are constantly doing inside of corrections with regards to hospice. Also, if you are in need of other professionals or paraprofessionals to meet the specific needs of the incarcerated. And I'm thinking of physical therapy, a speech therapist, occupational therapist as would be appropriate. Perhaps it's bringing in someone to help them meditate. Perhaps the chaplains would want to bring in someone if you're dealing with a Buddhist or someone with a faith that the chaplain is not aware of. The chaplain's world, we're going to get to that, is to make sure that their spirituality is, that they're facilitating the individual spirituality. We're not here to convert people to a particular, or evangelize or convert them to a particular set of beliefs, but the chaplain's role, as we'll go on here, is to make sure that the appropriate clergy is being connected to the patient as the patient's spiritual needs grow. And chaplain, you want to say, any of the chaplains on here want to say anything about that? Yeah, you're on mute. You have to unmute yourself again, chaplain. There you go.
You're absolutely correct. It's not an evangelistic opportunity, but it's the opportunity for you to have someone there that they want for spiritual guidance during that time.
Often, and in the free world, we see that as well. We have chaplains that go in to make sure that the patient is being connected to their own community, spiritual community support. It's not to take over, it's rather to make sure that they're facilitating that connection between the individual and their spiritual support in the community.
I think, if I may, that's one of the things we stress at Angola, and we're going to stress here, that we're not there to convert anybody, but to make them comfortable with whatever they believe in, whatever their beliefs are.
Yes.
Wow.
Thank you.
And another thing, if I may add, Tommy Floyd is home now.
He's home now?
Yeah, he's in Baton Rouge, Louisiana.
Good. Glad to hear that.
Yeah.
And then finally, one of the most important components of the IDT are your volunteers themselves. You have to remember that the volunteers meet their patients at the same level. And the volunteers and your patients can talk in a way that perhaps the professional staff and the correctional staff cannot communicate with that patient. Your volunteers are vital to that connection. You listen to your volunteers, and your volunteers will tell you things that maybe the patient can't express. I can't stress the programs that are most successful in this country are the programs that have incorporated this volunteer component that Angola has really, really developed over the past 25 years. Those programs are the programs that last longest. They're the ones where there's the most cooperation between the treatment staff as well as the correctional staff and security. The next domain is compliance with all laws and regulations. Every state has their own set of laws and standards around corrections, as well as whatever your certification is, whether it's through the American Correctional Association or some other entity. We want to make sure that, just like in the free world, you're following the policies and the laws of your setting, ensuring compliance with applicable laws, regulations, professional standards of practice, implementing systems and processes to prevent fraud and abuse. Stewardship and accountability. This is developing a qualified, diverse governance structure and senior leadership who share responsibility in the fiscal and managerial oversight. Hospice tends to save correctional facilities a lot of unwanted and futile care. And it's important that facilities exercise caution around not trying to force people to go into hospice, but that this is the individual's choice.
Jamie, one of the things about hospice, and I think it's going to be especially important in the corrections facility, we meet that patient where they are. We're not trying to take them someplace they don't want to go. They have an understanding that at this point, there is a final transition they're going to make.
Right.
Our responsibility, whether it be nurses, chaplains, social workers, whoever, is to meet them where they are and travel with them on that final transition.
Yes, sir. Thank you, Don. It's crucial, not only in terms of you finding or your program finding legitimacy inside of corrections, but that's true in the free world as well, in the community setting. We're not there to take or kidnap or force people into accepting. As I tell hospice providers all the time, hospice is not for everyone. And we cannot force hospice upon people. People have to want to be on this journey. They have to want us to be on their journey with them. Right now, in the Medicare population in Louisiana and Mississippi, about 52% of all the Medicare beneficiaries who die with hospice. It's not 100% because some people don't want don't want to go the hospice route. They want to fight until the bitter end, and they don't want to accept their terminal diagnosis. It's for some people it feels like giving up. Same's going to apply inside of corrections. There are going to be some people who are going to be very resistant to accepting their terminal diagnosis, and we have to respect that. And finally, there's performance improvement standard. And this is where you have an ongoing system of collecting and analyzing the data that you're receiving around the patients that you're serving in order to make sure that we're constantly working to improve the care that's being provided. Take 1 minute for you to read through these standards and to raise any questions that anyone may have around them. This is a patient satisfaction questionnaire that's also part of this manual. I encourage you to consider using this at different points. This can give you a lot of data about feedback from your patients as well. It's not that it's a way of documenting the feedback from your patients so that you have documentation from the patient themselves. And again, it's in the manual that you have a comment. Any questions or comments about anything that we've discussed today? And I apologize, we're at 1 minute over 2:31. We want to end pretty soon, but if you have any comments or questions, please feel free to ask them. Okay, in terms of educational requirements, I need you now to go into the chat box and I need you to type your name and then also your email address. I need both of those things and I need you to do that right now in order to qualify for continuing education credit. I want to remind everyone while you're doing that you have to have attended the entire session. And following today's session, within the next 24 hours, in your inbox, you will receive from us an evaluation form for today's session. You have to complete that evaluation in order to qualify for the 1 hour of continuing education that you will be getting for today. I want to remind you there are 4 sessions coming up with Marquetta over the coming 8 weeks that will go a little bit longer than 60 minutes. They actually go about 90 minutes. They're 4 out of the 8, or a little bit longer because of the subject matter. This session is being recorded, and I will be transferring it to a YouTube channel so that you will have access to it. However, I do want to remind everyone that just watching the YouTube or watching the recording will not get you, does not qualify you for continuing education. You have to have been on today's session live in order to receive that. Okay. That will do it. I appreciate your time and your attendance today. We will meet again next Tuesday at 1:30, not 1 o'clock, but 1:30, where Marquetta and Lisa will be taking over. Hello, Lisa. Thank you again. And Marquetta, thank you for taking over and providing the end of life training on palliative care. And There are 8 modules that we'll be going through over that time. If there are no other questions today, thank you again, and we can go ahead and sign off. I will be copying everybody's name and sending you all the evaluations. Like I said, within the next 24 hours, you should see it in your inbox. Thanks, everybody.
Thank you.